Welcome everyone to your Medical Teaching Unit rotation. My name is Dr. Prokopchuk Gauk, and I will be your staff attending physician for this week. Mita, I understand you were on call this weekend. Can you tell us about our first patient?
Yes, Mr. Mike McDonald is a 42-year-old gentleman admitted to hospital 2 days ago with a GI bleed. Gastroscopy on admission found a duodenal ulcer which was bleeding and was treated in the endoscopy suite with bleeding now stopped. History is significant for alcohol abuse, but otherwise unremarkable. Medications include a newly started proton pump inhibitor, and blood work this morning showed a hemoglobin of 76. I think he would benefit from a blood transfusion.
The decision to transfuse red blood cells is not a decision to be taken lightly. Physician intentions are good when ordering a transfusion, but it is important to remember that transfusion is not without risk. Alternatives should be considered. It may be more appropriate not to transfuse if your patient does not have overt symptoms of anemia and has no history of ischemic heart disease. When informed consent is obtained, it is essential to review risks, benefits, and alternatives in every patient case. Although the risk of viral transmission is less than 1 in 1.5 million, there are other risks to transfusion. These range from mild common reactions such as fever and hives to more severe but less common reactions like transfusion-related acute lung injury, overload, anaphylaxis, and hemolysis. Some experts say that the best transfusion is no transfusion, so other options should be considered in stable patients. Stopping blood loss is always a priority, and enhancing red cell production with supplementation with iron and folate may be safer and more effective than transfusion.
Do you know if the patient's been transfused since coming to hospital? And does he have any symptoms of anemia this morning?
I saw Mr. McDonald earlier before rounds, and he said he was still feeling tired and almost fainted yesterday. He received 2 units of packed red blood cells at the time of his gastroscopy with a post-transfusion hemoglobin of 79 yesterday. Since his hemoglobin is less than 80, I thought 2 more units of red cells would top him up and improve his overall physical status. I have ordered each unit to be transfused over 2 hours.
All right, so his physical symptoms of anemia make the transfusion order reasonable. However, what are your thoughts on transfusing 1 unit at this time rather than 2?
The expected rise in hemoglobin from transfusion of 1 unit of red cells is approximately 10 grams per liter, but this is influenced by several patient-specific factors. Research has demonstrated that in certain patient populations, transfusion to a hemoglobin level above 100 grams per liter can cause harm. Why give 2 when 1 will do? Consider transfusing only 1 unit of red cells to your patient, followed by clinical reassessment and checking of the post-transfusion hemoglobin. As an added benefit, the 2nd unit would now be available for another patient who may require it.
Explore everything CSTM can mean to you. Visit transfusion.ca to get the full list and continue to choose wisely.